Ever wonder what really makes you you? What incredible, intricate machinery is whirring inside your head, allowing you to think, feel, and even process the words you're hearing right now? Today, we're taking a deep dive into that ultimate frontier, your central nervous system. Our mission for you, our listener, is to truly master this information to understand the central nervous system and neuroanesthesia, not just academically, but with the insight and clinical acumen of an elite professional in the field. So we're not just scratching the surface, we're extracting the most critical concepts, the why it matters, from Chapter 31 of Nurse Anesthesia 7E to equip you with profound understanding.
What's truly fascinating here, and essential for an elite professional, is appreciating how intricately everything is connected. From the dance of the tiniest neuron firing to the complex effects of anesthesia, understanding these fundamental principles is absolutely critical. It's not just for neurosurgery, but for appreciating the inherent resilience and surprising vulnerability of our most vital system. This raises an important question, though. How does something so incredibly complex maintain its delicate balance? And what happens when that balance is disturbed, even subtly?
Okay, let's unpack this. Our journey begins at the very cellular level, exploring the fundamental building blocks. Then we'll zoom out to the major anatomical structures before dissecting the brain's electrical and chemical language, how it communicates. From there, we'll map out how everything connects to sensation and movement before finally turning to the fascinating high-stakes world of neuroanesthesia. We'll examine everything from the nuanced effects of specific drugs on the brain to the complex challenges posed by various surgical procedures. Get ready for some serious aha moments and deep insights into this incredible biological masterpiece. Right, so to begin our journey into the CNS, let's establish the grand organizational scheme. The nervous system, it's essentially divided into two major branches, right? The central nervous system, CNS, and the peripheral nervous system, PNS. Think of the CNS as the central command and processing unit that's your brain and spinal cord, the true core.
Exactly, the core. And the PNS, well, that's the vast communication network extending outwards.
Yeah.
All the cranial and spinal nerves, their receptors, basically everything connecting the CNS to the rest of the body, relaying information back and forth.
And the peripheral system isn't just one big blob. It subdivides intelligently.
Precisely. You've got the somatic nervous system, which is your voluntary control center. It handles conscious sensory input, touch, temperature, where your limbs are, and sends out commands to your skeletal muscles, stuff you decide to do. Then, in stark contrast, you have the autonomic nervous system, the ANS. This operates largely, in the background, controlling involuntary things like heart rate, digestion, breathing.
And that's broken down further.
It is. Into the sympathetic, the fight or flight system, the parasympathetic rest and digest, and the enteric nervous system, which handles the gut. For you, the elite professional, this distinction is absolutely foundational. Knowing which system controls what immediately helps frame how diseases, injuries, or even our anesthetic interventions might impact specific functions. Big difference between affecting voluntary muscle and, say, heart rate.
Makes sense. Okay, so from the big picture, let's zoom right in. To the actual building blocks, neurons. These are the fundamental units, the basic functional cells, really specialized for communication.
Highly specialized. And despite their different roles, they share a common structural blueprint. You've got the cell body, the perikaryon as the sort of main hub. Extending from it are these branching structures, the dendrites. Think of them as the neuron's inbox. They receive impulses and conduct them towards the cell body. Anterograde conduction, technically.
Okay, inbox. So the information comes in via dendrites. Then what?
Then, usually emerging from a spot called the axon hillock, you have a single projection, the axon. This is the outbox. It conducts impulses away from the cell body, sometimes over incredible distances.
Incredible distances, like how far?
Well, within the brain, they might only be a few millimeters, but think about the nerves going from your spinal cord down to your toes. Those axons can be a meter long. It's quite something. And they're diverse functionally, too. Motor neurons, usually multipolar, control muscles and glands. Sensory neurons, often pseudo-unipolar, are designed to receive all sorts of input, external, internal body position.
Proprioception, that's body position size.
Exactly, proprioceptive input. And then you have interneurons, the connectors, linking adjacent neurons, building those complex circuits within the CNS. It's this specialization, right down to their membrane structure with ion pumps and channels, that allows them to generate and transmit those electrical signals.
Aha moment. So like a highly specialized postal service, dendrites are the inbox, cell body, the main office processing everything, and the axon is the outbox, maybe sending messages across the country. That internal machinery makes it all work.
Good analogy. But neurons don't work alone. They exist in this complex ecosystem supported by neuroglial or glial cells. These guys don't signal electrically, but they are absolutely essential. They actually vastly outnumber neurons.
Outnumber them?
Really?
What do they do then, if not signaling?
A whole host of things. They maintain the perfect ionic environment neurons need. They modulate nerve conduction speed, control neurotransmitter reuptake, which fine-tunes the signals, and they're critical for repair after injury. And a sobering point, clinically speaking, most CNS tumors, brain cancers, actually arise from these glial cells, especially astrocytes.
So who are these vital support team members for that elite understanding?
Okay, the key players you need to know are, first, astrocytes. Most abundant, very versatile. They provide structure, regulate the metabolic environment, key in repair. They have these astrocytic feet on blood vessels thought to be crucial for forming the blood-brain barrier. We'll come back to that.
Okay, astrocytes. Who else?
Oligodendrocytes. These are the myelin makers inside the CNS brain and spinal cord. And here's a key point. One oligodendrocyte can wrap myelin around multiple axons. But a downside, they can't really regenerate after injury.
All right, multiple axons per oligodendrocyte in the CNS. Got it.
Then microglial cells. Smallest ones. They're the brain's immune cells, the cleanup crew. They rush to injury sites, turn into macrophages, and gobble up debris, essential for housekeeping.
And the last one?
Ependymal cells. These line the ventricles, the fluid-filled spaces in the brain, and the central canal of the spinal cord. They form the choroid plexus, which is the factory that secretes cerebrospinal fluid, or CSF. So another vital function. Understanding these support roles is absolutely critical.
That leads us perfectly to the myelin sheath. You mentioned oligodendrocytes make it in the CNS. It's all about speeding up communication, right? And saving space.
Absolutely. Myelin drastically increases nerve impulse conduction velocity, and it allows axons to be much smaller than they'd otherwise need to be.
Here's where it gets really interesting. Without myelin, a nerve would have to be double its size just to double its impulse conduction speed. Imagine if our whole nervous system was unmyelinated, we'd be these huge, slow-moving creatures.
It's an incredibly elegant biological solution. It insulates the axon, but not completely. It leaves these gaps, the nodes of Ranvier, where the voltage-gated sodium channels are concentrated. So the impulse doesn't crawl along the whole axon. It literally jumps from node to node. That's saltatory conduction, skips the insulated bits massively faster.
And you mentioned oligodendrocytes in the CNS. How is it different in the peripheral nervous system, the PNS?
Good distinction. In the PNS, myelin is formed by Schwann cells. And unlike oligodendrocytes, a single Schwann cell typically myelinates only one segment of one axon. It wraps around it layer after layer. The junctions between these Schwann cells, those are the nodes of Ranvier in the PNS, still the sites where the electrical impulse gets regenerated.
And what about nerve injury in the PNS? Can Schwann cells help with repair?
They can, remarkably. If a peripheral nerve is damaged, the Schwann cells can proliferate and form a kind of scaffold, guiding the regenerating axon back towards its target. Myelin regenerates first. It's a regenerative capacity largely missing in the CNS, unfortunately.
Okay, moving from the cellular level again. Let's talk protection. The blood-brain barrier, the BBB. You called it the brain's exclusive club. It's this highly selective barrier, right? Maintaining homeostasis.
Vital for neuronal function. The classic discovery was that IV dyes stained the whole body except the brain and spinal cord, showed they were uniquely protected.
So what actually makes up this barrier? It's not just a simple wall.
Not at all. It's a complex structure. Primarily, it's the endothelial cells lining the brain capillaries. But these are special. They have incredibly tight junctions between them, much tighter than elsewhere. No gaps, no fenestrae or pores. Plus, they're supported by other cells like pericytes, and they have astrocyte projections, those end feet wrapped around them. It makes it a really formidable barrier, especially for water-soluble molecules. And it has unique enzymes and transporters to actively control what gets in and out.
Super exclusive. But you mentioned earlier there might be parts without it, like a VIP entrance.
Sort of. There are a few specific areas, the circumventricular organs, that strategically lacks BBB. Places like parts of the hypothalamus, the pituitary gland, they need direct access to the bloodstream, maybe to monitor hormone levels or secrete neurochemicals directly into the blood. It's by design, but it does make them vulnerable points.
And what about when the BBB isn't working right, or when we might want to bypass it?
Well, it's not fully formed in newborns, which is why they're susceptible to things like kernicterus from bile pigments. And it can be disrupted by things like head injury, stroke, tumors, ischemia. Knowing this is key for us professionals. A disrupted barrier lets bad stuff in. But sometimes we intentionally disrupt it. We can inject hyperosmolar solutions into the carotid artery, for instance.
To do what? Shrink the cells?
Exactly. Temporarily shrinks the endothelial cells, opens those tight junctions just enough to sneak drugs through, like chemotherapy for a brain tumor. It's a really delicate balance, a high-stakes maneuver between protection and treatment access.
Okay, we've got the cells, the support, the barrier. Let's zoom out and navigate the brain's actual geography. Starting at the top, the cerebral hemispheres. This is the command center, right? The biggest, most developed part, handling all the higher level stuff.
Absolutely. That's where consciousness, thought, language reside. The outer layer, the cerebral cortex, is remarkably thin, only about 3 millimeters. But it's incredibly folded. You have the ridges, the gyri, and the grooves, the sulci or deeper fissures. This folding is genius. It dramatically increases the surface area, packing immense processing power into the skull.
And this cortex is divided into lobes.
Yes, 4 main lobes in each hemisphere, defined by major landmarks like the lateral fissure of Sylvius and the central sulcus of Rolando. Up front, the frontal lobe, executive function, planning, personality, and crucially, motor control via the precentral gyrus. Behind that, the parietal lobe, processing sensory input, touch, pain, temperature, proprioception in the postcentral gyrus.
Okay, frontal parietal. What about the sides and back?
On the sides, tucked under the Sylvian fissure, is the temporal lobe, auditory processing, memory, and language comprehension, like Wernicke's area. And at the very back, the occipital lobe, purely dedicated to processing visual information. And deep within these hemispheres are vital structures too. The corpus callosum, this huge fiber tract connecting the two halves, allowing them to communicate. The basal ganglia are crucial for modulating movement. The amygdala for emotion and stress response, and the hippocampal formation, absolutely essential for forming new memories.
So if the hemispheres are the command centers, what about the diencephalon? You called it the central relay station earlier.
That's a good way to think of it. It's located right in the middle, between the hemispheres. Its main job is processing and relaying information. Key components. The thalamus. This is like the grand central station for sensory info. Almost everything sensory passes through the thalamus on its way to the cortex. It integrates and directs traffic. Then there's the hypothalamus just below it, a master regulator. Controls hunger, thirst, body temp, sleep cycles, hormone release. Absolutely vital neurohumoral organ.
Okay, moving down from the diencephalon, we hit the brainstem. This sounds really critical, connecting the cerebrum to the spinal cord, housing life-sustaining centers.
It's absolutely critical. It consists of the midbrain, the pons, and the medulla oblongata. The pons acts as a bridge, connecting medulla and midbrain, carrying fiber tracts up and down, and housing nuclei for cranial nerves like trigeminal V and facial 7. The medulla oblongata at the bottom, merging into the spinal cord, is where the truly vital centers are. Respiratory control, cardiovascular control. Damage here is often incompatible with life. It also holds nuclei for many lower cranial nerves. And running through the brainstem is the reticular activating system, a diffuse network that's essential for keeping us conscious, awake, and alert.
Tucked away below the occipital lobe behind the pons and medulla is the cerebellum, the maestro of movement. What's its main role?
Coordination, balance, fine-tuning motor activity. It doesn't initiate movement, but it ensures it's smooth, accurate, and coordinated. It integrates massive amounts of information from the CNS and PNS about body position and intended movement, then sends corrective signals out. Think of it constantly making micro-adjustments to maintain muscle tone, equilibrium, and ensure your voluntary actions are graceful and precise, like the ultimate quality control supervisor for movement.
And wrapping all of this delicate machinery are the meninges, the protective layers, 3 membranes providing physical protection and forming these important spaces.
Right, from outside in. The tough duramater, which is 2 layers in the skull, 1 sticking to the bone, then the web-like avascular arachnoid mater, and finally, the thin pia mater, which clings directly to the surface of the brain and spinal cord.
But you mentioned the spaces between them are clinically key.
Absolute key for us. The subdural space between dura and arachnoid is a potential space. But bleeding here, like from tearing bridging veins, causes a subdural hematoma, a major issue. The subarachnoid space between arachnoid and pia is where the cerebrospinal fluid, CSF, circulates. It also contains the major blood vessels supplying the brain. Bleeding here, like from an aneurysm rupture, is a subarachnoid hemorrhage. SAH. And then specifically around the spinal cord, there's the epidural space outside the dura. This is where epidural anesthesia is administered. It contains fat and veins.
So what does this all mean? These layers aren't just padding. Knowing the spaces is critical for diagnostics, understanding hemorrhages, and even for delivering anesthesia like spinals and epidurals. Mastering these anatomical details is vital.
Precisely. And circulating within that subarachnoid space, bathing the entire CNS, is the cerebrospinal fluid, CSF. It's not just cushioning, it's actively controlling the brain's environment. There's about 150 millivell total in an adult, but here's the amazing part. It gets completely replaced every 3 to 4 hours. It's incredibly dynamic.
Where does it come from and where does it go?
It's secreted mainly by the choroid plexus, made of specialized ependymal cells located within the brain's ventricles, about 30 millimolars per hour. Then it flows in a specific path, from the lateral ventricles through the foramen of Monro to the third ventricle, down the aqueduct of Sylvius to the fourth ventricle, and then out into the subarachnoid space via the foramina of Magendie and Luschka. Finally, it gets reabsorbed back into the venous blood through arachnoid granulations, mainly into the superior sagittal sinus. This constant production, circulation, and absorption maintains pressure and chemical balance. Disruptions like a blockage cause hydrocephalus.
Got it. Let's follow that system down to the main information highway, the spinal cord, extending from the medulla, transmitting motor and sensory info.
Right. It runs down the vertebral canal, but it's actually shorter than the canal in adults. This means the lower lumbar and sacral nerve roots have to travel down before exiting, forming that bundle called the cauda equina, the horse's tail. Internally, you have that characteristic H shape of gray matter in the center. That's where the neuron cell bodies are, processing info. Surrounded by white matter, which consists of the myelinated axons, the fiber tracts running up and down, carrying signals rapidly.
And the gray matter has specific regions.
Yes, the dorsal posterior horns receive incoming sensory information. The ventral anterior horns contain the motor neurons sending commands out to muscles. The white matter tracts are also organized. Ascending sensory tracts tend to be dorsal, while descending motor tracts are more lateral and ventral. And critically, most major tracts decussate or cross over at some point.
So signals from one side often end up controlling or being processed by the other side.
Exactly. And peripheral nerves, as they exit, have their own protective coverings: epineurium, perineurium, endoneurium. And remember, conduction speed depends on diameter and myelination. Big myelinated A alpha fibers are the fastest. Small, unmyelinated C fibers are the slowest. Critical for understanding reflexes and sensation types. Okay, let's broaden our view again to the peripheral nervous system. We mentioned the somatic system for conscious control and sensation, and the autonomic nervous system, ANS, for the involuntary stuff. For you as an elite professional, really knowing the cranial nerves, table 31.2, is essential, especially for head and neck procedures. You've got purely sensory ones like olfactory 1 for smell, optic 2 for vision, motor ones like oculomotor 3 moving the eye, and mixed ones like trigeminal V for facial sensation and chewing, or facial 7 for facial expression. Damage to these has very specific clinical signs.
Let's dig into the autonomic system more, starting with the sympathetic nervous system, SNS, the fight or flight response. Where does it originate?
It's the thoracolumbar division. The preganglionic neurons arise from spinal cord segments T1 down to about L2 or L3. Their axons, the preganglionic fibers, exit the cord and typically enter the perivertebral ganglia, which form those sympathetic trunks running alongside the vertebrae. And here's a key feature. One preganglionic fiber can synapse with many postganglionic neurons, sometimes traveling up or down the chain first. This divergence explains why sympathetic responses tend to be widespread, a mass action.
And neurotransmitters, what chemicals are involved?
Important distinction here. The preganglionic sympathetic neurons release acetylcholine at the synapse within the ganglion. But the postganglionic neurons, the ones going to the target organs, release catecholamines, primarily norepinephrine, except for sweat glands, which get acetylcholine. Clinically, think about Horner syndrome, damage to the cervical sympathetics causing a constricted pupil, meiosis, drooping eyelid, ptosis, and lack of sweating, anhidrosis on one side.
Oh, wow.
Or how stimulating the thoracic sympathetics cranks up heart rate and contractility via beta receptors, a key target for our drugs.
Okay, that's fight or flight. Now the opposite. The parasympathetic nervous system, PNS, for rest and digest. Where does this one come from?
This has a craniosacral distribution. Preganglionic neurons originate either in the brainstem, traveling out with certain cranial nerves, 3, 7, 9X, and especially X, the vagus nerve, or from the sacral spinal cord segments, S2, S4.
And the neurotransmitters here?
This is a key difference. Both the preganglionic and the postganglionic parasympathetic fibers primarily release acetylcholine, Also, the postganglionic neuron is usually located in a small ganglion, very close to or even within the wall of the target organ. This setup allows for much more discrete, localized control compared to the sympathetic system's widespread effects. The vagus nerve, CNX, is the powerhouse here, responsible for about 75% of all parasympathetic activity, innervating the heart, lungs, and much of the digestive tract.
So it's this constant push and pull between sympathetic and parasympathetic that keeps things balanced?
Exactly. What's fascinating here is this functional antagonism creates a delicate balance, constantly adjusting our internal environment, our homeostasis. And as anesthetists, we're constantly navigating this balance. Our drugs can significantly tip it one way or the other, slowing the heart, dilating pupils, affecting gut motility. So understanding this interplay is fundamental to safe practice.
Right. All this complex signaling needs fuel. Let's talk vasculature of the CNS. The brain and spinal cord are incredibly dependent on a constant, uninterrupted blood supply for oxygen and glucose. How much blood does the brain actually demand?
It's astonishing. The brain is only about 2% of body weight, but it receives roughly 15% of the total cardiac output, around 50 milliliters of blood per 100 grams of brain tissue per minute. That highlights its immense metabolic activity.
And how does that blood get there? Is it one main pipe?
No, it's a clever dual supply system. You have the anterior circulation, which comes from the internal carotid arteries. These branch into the anterior and middle cerebral arteries, supplying most of the cerebral hemispheres. Then you have the posterior circulation, fed by the vertebral arteries, which branch off the subclavian arteries. They join to form the basilar artery near the pons, supplying the brainstem, cerebellum, and the back parts of the cerebrum.
And these two systems connect somewhere.
Yes, crucially, they connect at the base of the brain via the circle of Willis. This is an arterial anastomosis, a ring of connecting arteries. It includes parts of the anterior, middle, and posterior cerebral arteries and communicating arteries. It acts as a potential collateral pathway. If one major vessel gets blocked slowly, blood might reroute through the circle, though under normal conditions there's not much mixing between the anterior and posterior circulations.
What about the spinal cord supply? Is it as robust?
It's a bit more precarious, actually. It gets blood from the anterior and posterior spinal arteries, branching off the vertebrals, but also relies heavily on segmental radicular arteries coming off vessels like the intercostals and lumbars. And this supply isn't always continuous. There can be watershed areas. A critical vessel here, especially for elite professionals to know, is the artery of Adamkiewicz.
Ah, you mentioned that one earlier. Why is it so critical?
It's usually a single, large radicular artery, often arising around T7, though it can vary. It provides the major blood supply to the lower two-thirds of the spinal cord, the lumbosacral segment.
Listener alert. Imagine a city with only one major highway and then a critical side road that supplies half the city. That's essentially what the artery of Adamkiewicz is to your lower spinal cord, a single point of vulnerability. If that artery is compromised during surgery, say aortic surgery, the result can be devastating. Paraplegia. It underscores the critical importance of understanding spinal cord blood supply.
Okay, fuel supply covered. Now let's dive into electrophysiology. This is the language of nerve impulses, how neurons actually communicate electrically. It all boils down to ion movement across the neuronal membrane.
Starting with the resting state. What's happening when a neuron is just sitting there?
In its resting state, the neuron is polarized. There's an unequal distribution of ions. Much more sodium, Na+, outside the cell, and much more potassium, K+, inside. This creates a voltage difference, a potential, across the membrane. The inside is negative relative to the outside, typically around negative 60 to 90 millivolts. This is the resting membrane potential. The membrane is naturally leaky to potassium, letting positive charges leak out, but much less permeable to sodium. And crucially, this gradient is actively maintained by the Na plus K plus ATP pump, which constantly pumps sodium out and potassium in using energy.
Okay, so it's sitting there, charged up and ready. How does it fire? How does an action potential happen?
When a stimulus arrives, chemical, mechanical, electrical, that's strong enough to reach the threshold potential, usually about 20-30 millieves less negative than resting potential, it triggers a dramatic change. Specialized voltage-gated ion channels snap open. First, sodium channels open wide. Because there's so much sodium outside and the inside is negative, sodium ions rush into the cell. This massive influx of positive charge rapidly reverses the membrane potential. The inside becomes positive, maybe plus 30 or plus 40 milliV. That's depolarization.
So it flips from negative to positive. Then what?
Almost immediately, the sodium channels slam shut. And then, voltage-gated potassium channels open. Now, potassium, which is concentrated inside, rushes out of the cell, taking positive charge with it. This outflow of potassium brings the membrane potential back down, making it negative again. That's repolarization. The Na plus K plus pump then works to restore the original ion concentrations. The whole thing, depolarization and repolarization, is incredibly fast, happening in milliseconds. But during repolarization, there's a brief refractory period where the neuron can't fire again immediately.
Here's where it gets really interesting. This incredibly precise, rapid dance of ions across the membrane, sodium in, potassium out, is literally the fundamental basis of every single nerve signal. Thinking, moving, feeling, it all depends on this electrochemical event. And think about how many anesthetics work by interfering with these very ion channels, maybe blocking sodium channels to stop pain signals.
Okay.
The action potential travels down the axon. When it reaches the end, how does the message get passed to the next cell? That's synaptic transmission, right? The relay race.
Exactly. Information transfer happens at these specialized junctions called synapses. You have the neuron sending the signal, the presynaptic neuron, and the one receiving it, the postsynaptic neuron, separated by a tiny gap, the synaptic cleft.
Are all synapses the same?
No, there are two main types. Electrically mediated synapses have direct connections, gap junctions, allowing ions to flow straight through. They're very fast, always excitatory, found in places like cardiac muscle. But the vast majority in the CNS are chemically mediated. These involve neurotransmitters.
How do those work?
When the action potential arrives at the presynaptic terminal, it triggers voltage-gated calcium channels to open. Calcium ions, Ca2+, flood into the terminal. This calcium influx is the key signal. It causes tiny sacs, synaptic vesicles, which are preloaded with neurotransmitter molecules, to fuse with the presynaptic membrane. They then release their neurotransmitter cargo into the synaptic cleft via exocytosis.
So the electrical signal gets converted to a chemical signal, then what?
The neurotransmitter molecules diffuse across that tiny synaptic cleft and bind to specific receptors on the postsynaptic membrane, like a key fitting into a lock. This binding triggers a response in the postsynaptic neuron. If it's an excitatory neurotransmitter, like acetylcholine or glutamate, it typically opens channels that let positive ions, like sodium, in, making the postsynaptic neuron more likely to reach its threshold and fire its own action potential. Depolarization. If it's an inhibitory neurotransmitter, like GABA or glycine, it usually opens channels that let negative ions, like chloride, in, or positive ions, like potassium, out, making the inside more negative, hyperpolarization, and thus less likely to fire.
So it can either pass the go signal or a stop signal.
Precisely. And the effects can be very fast, milliseconds or slower, involving second messenger systems like tau-MP. This chemical step allows for incredible complexity, modulation, and integration of signals. But it also introduces a slight delay, the synaptic delay.
Which brings us squarely to the neurotransmitters themselves, the brain's chemical messengers. You said there are over 100?
At least. These are the molecules released in that calcium-dependent way, crossing the synapse to act on receptors. Each neuron typically synthesizes, packages, releases, and then degrades or recycles specific neurotransmitters. It's a tightly regulated process.
Okay, for an elite understanding, what are the absolute key players we need to know? Table 31.3.
Right, let's hit the highlights. Acetylcholine, ACH, primarily excitatory, crucial in the CNS at the neuromuscular junction controlling muscles, all ANS preganglionic fibers and postganglionic parasympathetic fibers, rapidly made, released, and broken down by acetylcholinesterase. Acts on two main receptor types, nicotinic and muscarinic.
Okay, EE. What about the ones involved in mood and arousal, the biogenic amines?
Good category. This includes the catecholamines, norepinephrine, NE, epinephrine, epi, and dopamine, DA, synthesized from tyrosine. NE is released by most sympathetic postganglionic neurons and is generally inhibitory in the CNS, reticular activating system, hypothalamus. Dopamine is the predominant one in the CNS, concentrated in the basal ganglia, mainly inhibitory, crucial for movement control reward pathways. Parkinson's involves loss of dopamine neurons. Also in this group are serotonin, mostly inhibitory, heavily involved in mood, sleep, appetite, and histamine, also inhibitory, involved in arousal. These often work via slower second messengers, and their action is often terminated by reuptake back into the presynaptic terminal.
What about amino acids? I know glutamate and GABA are big ones.
Huge ones. Glutamate is the primary excitatory neurotransmitter throughout the brain, especially cortex and hippocampus, essential for learning and memory. But too much glutamate can be toxic excitotoxicity, implicated in damage after stroke or trauma. It acts on receptors like the NMDA receptor. Conversely, GABA, gamma-aminobutyric acid, is the major inhibitory neurotransmitter. Found everywhere: basal ganglia, cortex, cerebellum, spinal cord. It works mainly by opening chloride channels, hyperpolarizing the neuron, making it resistant to excitation. Many sedatives and anti-anxiety drugs enhance GABA's effects. And glycine is another key inhibitory transmitter, primarily in the spinal cord.
And neuropeptides, like opioids.
Yes, neuropeptides are another class. They can be excitatory or inhibitory. The opioids like endorphins and enkephalins are endogenous morphine-like substances. They act at opiate receptors, mu, delta, kappa, throughout the pain pathways in the brain and spinal cord. They block slow pain signals, raise the pain threshold, but they also cause side effects like respiratory depression. Substance P is another important one, excitatory, involved in transmitting pain signals in the spinal cord.
Wow, that's a complex chemical soup controlling everything.
It really is connecting the dots.
Yeah.
This intricate cocktail explains why even small imbalances, too much dopamine, too little serotonin, blocked acetylcholine, can profoundly affect everything from movement and mood to breathing and memory. And that's why neuroanesthesia demands such a nuanced approach, constantly considering how our drugs are interacting with this delicate chemical balance.
Okay, we've covered the brain's internal language. Now, let's map out the body's communication superhighways, the sensory and motor pathways connecting the CNS to the periphery. Let's start with how we feel the world. The sensory pathways, these are the afferent routes, bringing information into the CNS.
Right. They transmit all sorts of information. Pain, temperature, pressure, touch, vibration, proprioception, body position, plus the special senses like vision and hearing. This information originates from specialized receptors. Some are near the surface, exteroceptors, others deeper, proprioceptors in muscles, joints. You have specific structures like Pacinian corpuscles detecting vibration, free nerve endings for pain, muscle spindles for stretch, a whole array of detectors.
And these receptors connect to nerves that head towards the CNS.
Exactly. They connect to the first-order neurons, whose cell bodies are typically located in ganglia just outside the CNS, like the dorsal root ganglia for signals from the trunk and limbs, or the trigeminal ganglion for most of the head. These neurons carry the initial signal into the spinal cord or brainstem.
Let's trace a specific pathway. How about pain and temperature? These use the anterolateral system, you said.
Correct. This pathway transmits vital protective information. Let's take signals from the trunk and limbs as an example. The first-order neuron enters the spinal cord's dorsal horn. It synapses there with the second-order neuron. And here's the crucial step. The axon of this second-order neuron immediately decussates, crosses over to the opposite side of the spinal cord within the ventral commissure.
Crosses right away.
Right away. Then it ascends in the contralateral anterior and lateral white columns, forming the spinothalamic tracts. It travels all the way up to the thalamus, specifically the ventral posterolateral nucleus, where it synapses with the third-order neuron. Finally, the axon of the third-order neuron projects from the thalamus through the internal capsule to the postcentral gyrus of the cerebral cortex, the primary somatosensory area, where the sensation is consciously perceived and localized.
So immediate crossing in the cord is key for pain and temp. What about reflexes?
Yes. Some of those incoming pain fibers also synapse with interneurons in the dorsal horn, which then connect directly to motor neurons in the ventral horn. This forms a reflex arc, allowing for rapid, automatic withdrawal from painful stimuli before the signal even reaches the brain for conscious awareness. And remember dermatomes, those specific skin areas innervated by single spinal nerve roots? There's overlap, especially for pain and temp, but knowing the dermatome map is crucial for localizing spinal cord lesions.
Okay, what about pressure and crude touch pathways? Are they the same?
Similar, but a bit more complex and less precise than fine touch. The pathways involve fibers that also enter the dorsal horn. Some cross over relatively quickly, like pain-temp fibers, and ascend in the ventral spinothalamic tract. However, other fibers ascend ipsilaterally on the same side in the dorsal columns for several segments before eventually crossing over. There's more branching and redundancy.
What's the clinical significance of that redundancy?
It means that spinal cord injuries rarely cause a complete loss of crude touch and pressure sensation below the level of the lesion, because there are multiple pathways, both crossed and uncrossed, carrying similar information.
Now for the high-fidelity pathway. Vibratory sense, proprioception, and discriminatory fine touch. This uses the dorsal column medial lemniscal system. How does this differ?
Big differences. Figure 31.13. First, the first-order neuron enters the spinal cord and immediately ascends in the dorsal white column on the ipsilateral side. No crossing yet. These fibers travel all the way up to the medulla. Fibers from the lower body are medial in the fasciculus gracilis. Fibers from the upper body are lateral, fasciculus cuneatus. In the medulla, they finally synapse in the nucleus gracilis or nucleus cuneatus. It's the axons of these second-order neurons that then decussate, cross over, and form the medial lemniscus, which ascends to the thalamus ventral posterolateral nucleus again.
So the crossing point is much higher up in the medulla compared to pain-temp.
Exactly. And then, like the other pathway, third-order neurons project from the thalamus to the postcentral gyrus. The key distinctions, box 31.1. Dorsal column system uses large myelinated fibers, maintains precise spatial orientation, transmits rapidly, perfect for fine touch, vibration, position sense. Anterolateral system uses smaller fibers, less spatial orientation, slower, carries pain, temperature, crude touch. Understanding these two major sensory roads is fundamental.
Okay, we've covered getting information in. Now, how do we get commands out? The motor pathways, these are the efferent pathways, carrying signals from the brain to muscles and glands.
Right. The main players for voluntary movement are the corticospinal tracts for the trunk and limbs, and certain cranial nerves for the head and neck. Plus, the autonomic free ganglionic fibers originate in the CNS to control smooth muscle, cardiac muscle, and glands.
Let's focus on the big one for voluntary movement. The corticospinal tract, also called the pyramidal tract.
This is the major highway for conscious muscle control. It originates from large upper motor neurons, UMNs, located primarily in the precentral gyrus motor cortex of the frontal lobe. There's a map here. The motor homunculus areas for intricate movements like the hands have huge representation. The axons from these UMNs descend through the internal capsule, a critical white matter structure, deep in the brain. Then through the midbrain down into the medulla, where they form visible bumps called the pyramids.
And this is where the crossing happens.
This is the major crossing point, figure 31.14. In the lower medulla, about 90% of the corticospinal fibers decussate, crossing to the opposite side. These crossed fibers form the lateral corticospinal tract, which travels down the spinal cord. At each spinal level, these fibers synapse, often via interneurons, with lower motor neurons, LMNs, and the ventral horn gray matter. The remaining 10% or so don't cross in the medulla. They descend as the ventral corticospinal tract. Most of these fibers do cross over near the level where they synapse with LMNs. Finally, the axons of the LMNs exit the spinal cord via the ventral roots and travel in peripheral nerves to innervate skeletal muscles.
So damage to the UMNs versus the LMNs would look different clinically?
Very different. UMN paralysis, damage anywhere from cortex down to synapse and spinal cord, causes weakness or paralysis, but reflexes are often hyperactive, spasticity, because inhibitory influences are also lost. If the damage is above the medullary decussation, the deficit is contralateral. If below, it's ipsilateral. LMN paralysis, damage to the ventral horn cell or its axon, causes weakness or paralysis too. But the muscle becomes flaccid, loses tone, and reflexes are diminished or absent. Understanding this distinction is crucial for neurological diagnosis.
What about motor control for the head and neck muscles? How does that work?
That's primarily handled by cranial nerves with motor functions. The upper motor neurons for these are also in the motor cortex near the lateral fissure. Their axons form the corticobulbar tracts, which descend through the internal capsule, mainly the genu, to the brainstem. In the brainstem, they synapse with the lower motor neurons located in the specific cranial nerve nuclei. For example, CNVN, oculomotor for eye muscles, CNV, trigeminal for chewing, FND, facial for facial expression, CN12, hypoglossal for tongue muscles.
Does the bilateral input rule apply here too, like for the sensory cranial nerves?
Mostly, yes. Most cranial motor nuclei receive input from both cerebral hemispheres via the corticobulbar tracts. This provides some redundancy, but there are critical exceptions an elite professional must know. The LMNs controlling the muscles of the lower face via CN7 and most of the tongue muscles via CN12 receive input predominantly from the contralateral hemisphere only. This explains why a unilateral stroke often causes contralateral lower facial droop and tongue deviation, but spares the upper face, which gets bilateral input.
Okay, so we have the direct cortical control, but you mentioned subcortical motor areas that modulate movement. What are those?
Right, these are areas outside the cortex, often considered more primitive, that refine and coordinate motor output. The basal ganglia are key players here. These are large nuclei deep within the hemispheres, the caudate, putamen, globus pallidus. They form complex loops with the cortex and thalamus, involved in initiating and sequencing movements, suppressing unwanted movements, and regulating muscle tone. Dopamine from the substantia nigra is a critical neurotransmitter here.
And damage here causes things like Parkinson's.
Exactly. Parkinson's involves the degeneration of dopamine-producing cells in the substantia nigra, disrupting basal ganglia function, leading to tremor, rigidity, and slow movement. Huntington's chorea involves degeneration in the caudate and putamen, causing excessive involuntary movements. Other subcortical areas include the subthalamic nucleus, the red nucleus in the midbrain, giving rise to the cerebrospinal tract influencing flexors, and the reticular formation throughout the brainstem, which has tracts, reticulospinal, that modulate posture and muscle tone, particularly for extensors.
So damage to these subcortical areas doesn't cause paralysis like corticospinal damage, but rather problems with tone and involuntary movements.
Precisely. You get dyskinesias, abnormal involuntary movements, or significant changes in muscle tone, rigidity, dystonia. This raises an important question. How do these deeper, often subconscious areas coordinate so seamlessly with the conscious commands from the cortex? It highlights that movement isn't just a simple top-down command. It's a highly complex, multi-layered process. And understanding what goes wrong in diseases like Parkinson's requires appreciating this intricate interplay.
We've built a solid foundation of the CNS anatomy and physiology. Now let's bridge this knowledge directly into the operating room, the world of neuroanesthesia, protecting that delicate brain during surgery. What are the core principles here?
The absolute core principle for an elite professional is understanding how our anesthetic choices impact critical cerebral dynamics. We must consider the effects on cerebral blood flow, CBF, cerebral blood volume, CBV, intracranial pressure, ICP, the brain's oxygen use rate or cerebral metabolic rate of oxygen consumption, CMRO2, and something called cerebral compliance, basically, the brain's ability to buffer volume changes.
And these are all interconnected.
Intricately. And they all influence cerebral perfusion pressure, CPP, which we calculate as mean arterial pressure, MAP, minus intracranial pressure, ICP. Maintaining adequate CPP is paramount to prevent brain ischemia. So our anesthetic goal is always a comprehensive plan, tailored to the patient's condition, their comorbidities, and the specific demands of the surgery positioning, surgical approach, monitoring needs, everything.
Okay, let's unpack this. This is where that deep anatomical and physiological knowledge meets the very practical, high-stakes decisions in the OR, where mastering this information truly pays off. Let's start with inhalation agents, the anesthetic gases. What are their general effects on the brain?
Table 31.4. As a rule of thumb, most potent volatile anesthetics, isoflurane, sevoflurane, desflurane, tend to cause cerebrovascular dilation. They decrease cerebrovascular resistance. This dilation increases cerebral blood volume, CBV, which can lead to an increase in ICP. This effect is dose-dependent and more pronounced if ICP is already high. They also impair the brain's ability to autoregulate blood flow. On the plus side, they decrease the brain's metabolic rate, CMRO2, which can be protective. But that initial ICP rise from vasodilation is often a major concern for us.
Are there significant differences between them, isoflurane versus sevoflurane, for example?
There are nuances. Isoflurane generally causes the most vasodilation and potential ICP increase. Its effects on CVF become significant above about 1 MAC. There's been talk about neuroprotection, maybe via potassium channels or reduced excitotoxicity, but solid clinical proof is lacking. Desflurane stands out for its very low solubility in blood. This means patients wake up very quickly when you turn it off, a big plus for rapid post-op neurological checks. Its effects on CBF-CMRO2 are similar to isoflurane. Sevoflurane is often considered a bit kinder to the brain vasculature. It seems to cause the least vasodilation among the three and preserves cerebral autoregulation up to higher concentration, around 1.5 MAC. This often makes it a preferred agent for maintenance in intracranial surgery.
What about nitrous oxide, N2O? You mentioned it's controversial. Why?
Highly controversial. It can increase CBF, CMRO2, and ICP. But the biggest issue for neuroanesthesia, the absolute contraindication, is its physical property. It's much more soluble than nitrogen in the air. This means if there's any trapped air inside the skull, pneumocephalus, maybe from previous surgery, trauma, or even during the current procedure, N2O will rapidly diffuse into that air pocket and cause it to expand dramatically.
Like blowing up a balloon inside the head.
Exactly. It can cause a dangerous rise in ICP, known as tension pneumocephalus. Similarly, if there's a risk of venous air embolism, VAE, N2O will expand those air bubbles in the bloodstream, potentially leading to cardiovascular collapse. Because of this, box 31.2, many neuroanesthetists avoid N2O completely, or make absolutely sure to discontinue it long before the dura is closed to prevent trapping air that could then expand. So what does this all mean? This isn't just about putting someone to sleep. It's a constant, delicate balancing act, managing hemodynamics, ICP, brain metabolism, demanding precise knowledge of how each drug interacts with the brain's physiology.
Let's switch to the intravenous agents. Propofol is incredibly common, right?
Very popular for both induction and maintenance. Its key advantage is that it causes a significant dose-dependent reduction in both CBF and CMRO2, often by 40–50%. This metabolic suppression, combined with some cerebral vasoconstriction, leads to a desirable reduction in ICP. The main caution is to avoid significant hypotension, which would counteract the benefit by reducing CTP. Careful titration is key.
What about etomidate?
Etomidate also reduces CMRO2 and CBF and has the benefit of causing cerebral vasoconstriction, lowering ICP often without dropping blood pressure as much as propofol might. Good for CPP. However, its major drawback, a big one, is adrenocortical suppression. It inhibits cortisol synthesis. This is particularly concerning in critically ill patients or those with TBI who need a robust stress response. Because of this risk, many clinicians avoid it in neurosurgery or, if used, consider stress dose steroid coverage.
You mentioned dexmedetomidine is gaining popularity. What makes it special?
Dexmedetomidine is an alpha-2 agonist, and it's unique. It provides sedation, anxiolysis, and some analgesia, but crucially, without significant respiratory depression. Patients remain cooperative and easily arousable. This is invaluable for procedures requiring intraoperative neurological testing, like wake-up tests or awake craniotomies. It doesn't interfere much with electrophysiologic monitoring, EEG evoked potentials. Interestingly, it decreases CBF, vasoconstriction, but doesn't seem to alter CMRO2, suggesting an uncoupling of flow and metabolism.
Yep.
ICP effects aren't usually significant. Its use in awake craniotomy is probably its greatest application right now. And opioids, fentanyl, remifentanyls, they're staples. Yes. The synthetic opioids are popular for providing hemodynamic stability and allowing predictable emergence. They generally cause dose-related reductions in CBF and CMRO2. A potential issue is that large induction doses can sometimes cause a transient rise in ICP, possibly due to a brief drop in MAP, triggering autoregulatory vasodilation. Careful titration is needed. Remifentanil is particularly useful due to its ultra-short action and metabolism independent of liver kidney function, allowing very fine control and rapid awakening. The main drawback is the lack of residual analgesia post-op. We strictly avoid meperidine because its metabolite, normeperidine, lowers the seizure threshold. And reversing opioids with naloxone requires extreme caution to avoid sudden, dangerous hypertension and sympathetic surge.
What about benzodiazepines like midazolam?
Benzos provide anxiolysis, amnesia, and anticonvulsant effects. They cause a dose-dependent decrease in CMRO2 and subsequent reductions in CBF. Generally, they have minimal effects on ICP when used appropriately. Reversing them abruptly with flumazenil after high doses might cause a rebound increase in CBF-ICP, so caution is needed.
Finally, ketamine. Still somewhat controversial.
It has been. Historically, the concern was significant increases in CBF and potentially ICP. But the thinking has evolved. Recent evidence suggests that, especially when ventilation is controlled and it's co-administered with a GABA agonist like propofol, the ICP increase might not be as dramatic as feared. Its main advantage is preserving hemodynamic stability, especially in hypovolemic trauma patients. Plus, its NMDA receptor antagonism offers potential neuroprotective benefits, and it provides analgesia. So while not a first-line agent for many elective cases, it has a definite role in specific situations, particularly TBI with hypotension, demanding a nuanced understanding of its effects. Now let's touch on neuromuscular relaxants, the drugs we use to ensure the patient remains perfectly still. Generally, the non-depolarizing agents like rocuronium, microronium don't have significant direct effects on CBF or CMRO2 if blood pressure remains stable. However, key point for elite practice. Patients with upper motor neuron disease, like from a stroke, might show resistance to these relaxants on the affected side, so you need to monitor neuromuscular function on the unaffected side. Also, patients on chronic anticonvulsant therapy might metabolize some relaxants faster, requiring higher doses.
What about the depolarizing agent succinylcholine? Still used?
It can be, especially for rapid sequence induction when a difficult airway is anticipated because it works very fast. However, it can cause transient increases in ICP, maybe 10–15 mmHg for a few minutes. This is thought to be related to increased CBF and muscle fasciculations, especially in the neck, impeding venous outflow. But the absolute major concern with succinylcholine in neuropatients is the risk of life-threatening hyperkalemia if the patient has denervated muscle from stroke, spinal cord injury, TBI, prolonged immobility, burns. In these cases, the muscle membrane upregulates acetylcholine receptors, and succinylcholine triggers a massive release of potassium. It's absolutely contraindicated.
So what's the alternative for rapid paralysis in those patients?
Rocuronium, especially at a higher dose, like 1.2 mg/kg, provides intubating conditions almost as quickly as succinylcholine, 60–90 seconds, but without the hyperkalemia risk. And now, with the reversal agent Sugammadex, we can rapidly reverse deep rocuronium blockade, making it a much safer and more versatile option in neuroanesthesia.
Lastly, let's look at antihypertensives. Managing blood pressure is so critical.
Absolutely critical. Beta blockers like esmolol and labetalol are workhorses. Esmolol is fantastic for blunting the heart rate and blood pressure surge during laryngoscopy and intubation because it's very rapid-acting and short-lived. Minimal ICP effects. Labetalol has combined alpha-1 and non-selective beta blockade. It's often preferred for controlling hypertension during emergence from anesthesia. It might cause more bradycardia than esmolol post-op, though. But we need to be very cautious with direct vasodilators like sodium nitroprusside and nitroglycerin.
Why is that? They lower blood pressure effectively.
They do, but they achieve it by directly dilating blood vessels, including cerebral capacitance vessels. This directly increases cerebral blood volume, CBV, and therefore increases ICP. In a patient who already has poor intracranial compliance, a tight brain, this sudden increase in volume can be catastrophic, potentially leading to herniation. So these agents are generally considered unsafe or used with extreme caution and only if absolutely necessary in patients with known or suspected intracranial hypertension.
Here's where it gets really interesting. Managing blood pressure in neurosurgery is truly a high-wire act. Drop it too low, you risk starving the brain of oxygen ischemia. Let it get too high, you risk bleeding into the surgical site, aneurysm rupture, or worsening brain swelling and ICP. These drugs, beta blockers, sometimes calcium channel blockers, but avoiding potent vasodilators are the precision tools needed to walk that tightrope. It requires constant vigilance and a deep understanding of both the drugs and the patient's specific cerebral physiology.
Exactly. That brings us squarely to intracranial pressure, ICP itself. Understanding this is fundamental. ICP is defined as the pressure of the cerebrospinal fluid, CSF, within the supratentorial space, usually measured in a ventricle or over the brain surface. And the key principle governing it is the Monro-Kelly doctrine. Think of the skull as a rigid, fixed box. Inside are three main things: brain tissue, about 80–90%, blood, and CSF.
And the total volume inside that box has to stay constant.
Essentially, yes. So if one component increases in volume, say due to brain swelling, edema, a hematoma, or excess CSF, another component must decrease to compensate and keep the overall pressure stable. Initially, the brain can compensate, mostly by shunting CSF out into the spinal canal or reducing venous blood volume. This is normal elastance or compliance.
But there's a limit to that compensation.
Absolutely. Once those compensatory mechanisms are exhausted, you reach a critical point. Beyond that, even a tiny additional increase in volume causes an exponential rise in ICP. This is incredibly dangerous because high ICP does two terrible things. First, it reduces cerebral perfusion pressure, CPP equals MAP ICP, potentially causing global brain ischemia. Second, it can cause physical shifting and herniation of brain tissue, pushing it against rigid structures like the falx or contorium, or even down through the foramen magnum, which is often fatal.
What's considered normal ICP, and when does it become dangerous hypertension?
Normal ICP in adults is typically 5 to 15 millimeters of mercury, mmHg. Intracranial hypertension is generally defined as sustained pressures greater than 20 to 25 mmHg. That level warrants urgent investigation and treatment.
How do we actually measure this? You can't just put a blood pressure cuff on the brain.
No, you can't. We need invasive monitoring. Methods include placing sensors directly into the brain parenchyma, intraparenchymal probes, or, the gold standard, placing a catheter into one of the lateral ventricles, intraventricular catheter. The intraventricular catheter is considered the gold standard because it's very accurate and allows us to therapeutically drain CSF if the pressure gets too high. However, it's more invasive and carries a higher risk of infection. Intraparenchymal probes are easier to place and have lower infection rates.
When is ICP monitoring typically recommended?
The main indication is severe traumatic brain injury, TBI specifically, a Glasgow Coma Scale, GCS, score less than 9, and an abnormal CT scan showing things like hematomas or swelling. It might also be considered in severe TBI with a normal CT if other risk factors are present, like being over 40 or having abnormal motor posturing.
And the monitor gives more than just a single number, right? There are waveforms.
Absolutely. For the elite professional, interpreting the ICP waveform provides much richer information than just the mean pressure. A normal waveform is pulsatile, reflecting the cardiac cycle, and typically has 3 peaks. P1, percussion wave, usually tallest, P2, tidal wave, and P3, dicrotic wave. As intracranial compliance decreases and ICP rises, the shape changes. P2 starts to rise, eventually becoming taller than P1. The waveform can lose its distinct peaks and become more rounded or triangular. This indicates the brain is losing its ability to compensate.
Are there specific dangerous waveform patterns?
Yes. The most ominous are plateau waves, also called A waves of Lindbergh. These are sudden, dramatic spikes in ICP, reaching 40, 50, even 100 millimeter Hg, lasting for several minutes. They reflect critically low compliance and are often associated with cerebral ischemia. They're a sign that the brain is really struggling. And then there's the clinical sign, the Cushing triad or Cushing reflex. Systemic hypertension, often with a widening pulse pressure, bradycardia, and irregular respirations. This is a latent gray sign of severely increased ICP, indicating pressure on the brainstem and impending herniation. Here's where it gets really interesting. Monitoring ICP isn't just about chasing a number. It's about interpreting these dynamic waves, understanding what they tell you about compliance and perfusion in real time. It's like listening to the brain's vital signs directly. So intracranial hypertension that's sustained ICP above 20 to 25 millimeter Hg can be caused by many things. An expanding mass like a tumor or hematoma, blockage of CSF flow causing hydrocephalus, excessive cerebral blood flow, or widespread brain edema. Often it's multifactorial. The consequences, if untreated, are dire. Initially, symptoms might be subtle headache, nausea, but as pressure rises, you see neurological deficits, altered consciousness, seizures, coma. The real danger is that vicious cycle. High ICP compresses blood vessels, reducing CBF, causing ischemia. Ischemia leads to more edema, which further increases ICP, leading to more ischemia, neuronal damage, and herniation.
It sounds like a downward spiral. How do we break that cycle? What are the treatment strategies to reduce ICP? Box 31.3.
It requires a multi-pronged approach, often simultaneously. The absolute basics are ensuring a patent airway, adequate oxygenation, and controlled ventilation. Simple positioning helps. Elevating the head of the bed 15-30 degrees, if tolerated hemodynamically and surgically, improves venous drainage from the brain. Keeping the head midline and avoiding tight neck collars or ties is crucial to prevent jugular vein compression. Maintaining normovolemia, avoiding overhydration, and optimizing hemodynamics, MAP, CPP, are key. Sometimes surgical decompression is needed as a last resort. Mild hypothermia has been explored but hasn't shown consistent benefit for TBI outcomes, though it might have a role in refractory ICP.
What about specific interventions like hyperventilation?
Hyperventilation works temporarily. Lowering PaCO2 causes cerebral vasoconstriction, reducing CVF and CVV, thus lowering ICP. However, the big risk is causing too much vasoconstriction, leading to ischemia. So, current guidelines generally recommend against prophylactic or aggressive hyperventilation, especially early after TBI. If used, it should be brief, targeted, maybe PaCO2 30-35 mmHg, and ideally guided by monitoring of brain oxygen or blood flow to treat acute, dangerous ICP spikes. Its effect wears off after several hours anyway as CSF pH equilibrates.
Another option is draining CSF.
Yes, CSF drainage via an intraventricular catheter, ventriculostomy, is a very effective way to directly reduce intracranial volume and pressure. We can drain CSF intermittently or continuously to target a specific ICP level. It's limited if the ventricles are collapsed or if the primary problem is massive brain swelling rather than excess CSF.
Let's talk pharmacology. Diuretics are commonly used, right?
Yes, primarily two types. Osmotic diuretics, with mannitol being the classic example. Given intravenously, it increases the osmolarity of the blood. Because the blood-brain barrier, if intact, largely prevents mannitol from entering the brain, it creates an osmotic gradient that pulls water out of the brain tissue and into the blood vessels, effectively shrinking the brain and lowering ICP. Its effect starts within minutes and can last for hours. We give it as a bolus, typically 0.25 to 1 gram per kilogram. Need to watch for dehydration and electrolyte imbalances with repeated doses. The other major player now is hypertonic saline. Solutions like 3% or even 23.4% saline work similarly to mannitol, creating an osmotic gradient to draw water out of the brain. It might have some additional benefits like improving hemodynamics, increasing MAP and CPP, and reducing inflammation.
Is one better than the other, mannitol or hypertonic saline?
The jury is still somewhat out, and practice varies. Some studies suggest hypertonic saline might be more effective or have a longer duration, especially as a continuous infusion. But it carries risks too, particularly rapid increases in serum sodium, which can cause osmotic demyelination syndrome, central pontine myelinolysis. Careful monitoring of serum sodium and osmolality is essential with either agent. We typically aim for a target serum sodium of 145 or 155 millirEQL when using hypertonic saline.
What about corticosteroids like dexamethasone?
Corticosteroids are very effective at reducing vasogenic edema, the type of swelling often seen around brain tumors or abscesses. They stabilize cell membranes and reduce capillary permeability. So they are standard treatment for edema associated with mass lesions, often given preoperatively. However, and this is critical, the large CRH trial showed that corticosteroids are harmful in acute traumatic brain injury. They actually increase mortality, so they should be avoided in TBI patients.
And the last resort, medically. Barbiturate coma.
Yes, inducing a coma with high-dose barbiturates, like pentobarbital, is sometimes used for refractory intracranial hypertension, meaning ICP remains dangerously high despite all other measures. Barbiturates dramatically reduce the brain's metabolic rate, CMRO2, which in turn reduces CBF and ICP. They might also have some neuroprotective effects like scavenging free radicals. The goal is often to induce an EEG pattern called burst suppression, which indicates maximal metabolic suppression. The major downside is profound hypotension, which can be difficult to manage and counteracts the benefit by lowering CPP. It also completely prevents neurological examination. While it can lower ICP, it hasn't consistently shown improved outcomes in TBI, but remains an option in dire situations.
This section really highlights the urgency and the complexity. Managing that pressure inside the skull isn't just one drug or maneuver. It's this dynamic, multifaceted approach, a real orchestra of interventions needing constant adjustment based on monitoring and the patient's response.
Okay, we've talked about managing the brain's environment. Now, how do we actually listen in during surgery to make sure things are okay? That's where intraoperative neurophysiologic monitoring, or IOM, comes in.
Exactly. IOM uses various electrophysiological techniques to assess the functional integrity of the nervous system, brain, spinal cord, specific nerves during procedures where they might be at risk. It's become routine for many neurosurgical cases. It helps identify neural structures, guides the extent of resection, like in tumor or epilepsy surgery, and provides early warning of potential injury, allowing surgeons to modify their technique before permanent damage occurs. It has significantly improved patient outcomes. What are the main types of monitoring used? What signals are we listening for? Box 31.4.
Several key modalities, often used in combination. Electroencephalography, EEG. This records the brain's overall cortical electrical activity, those summated postsynaptic potentials. It's sensitive to changes in blood flow, and oxygenation ischemia causes slowing of the EEG waves. It's very useful during carotid endarterectomy, for example, to assess if a shunt is needed. Anesthetics also affect the EEG, causing dose-dependent slowing or burst suppression at deep levels.
So EEG gives a global picture of the cortex. What about specific pathways?
For that, we use evoked potentials, EPs. These measure the nervous system's electrical response to a specific stimulus. We average the signal over many repetitions to pull it out from the background noise. Somatosensory evoked potentials, SSEPs, are very common. We stimulate a peripheral nerve, like the median nerve at the wrist or tibial nerve at the ankle, and record the signal as it travels up the spinal cord, through the brainstem and thalamus, to the sensory cortex. A significant decrease in amplitude or increase in latency suggests injury somewhere along that pathway. SSPs are crucial for spinal cord surgery.
Does anesthesia affect SSFPs?
Yes, significantly. Volatile anesthetics and nitrous oxide depress SFP amplitude in a dose-dependent manner. Bolus doses can mimic ischemic changes. That's why total intravenous anesthesia, TIVA, often using propofol and an opioid, is frequently preferred when reliable SFP monitoring is critical. Etomidate and ketamine actually increase SFP amplitude, interestingly.
Okay, SSFPs for sensory pathways. What about hearing and the brainstem?
For that, we use brainstem auditory evoked responses, Bay ears or ABRs. We present clicking sounds to the ear and record the very small electrical responses generated as the signal travels through the auditory nerve, CNETH, and up the brainstem pathways. Bay ears are remarkably robust. They are much more resistant to anesthetic effects and oxygen deprivation than EEG or SFPs. This makes them excellent for monitoring brainstem integrity during posterior fossa surgery, like acoustic neuroma resection or microvascular decompression, where the auditory nerve and brainstem are at direct risk.
What about monitoring motor nerves, like the facial nerve during ear or parotid surgery?
That's where electromyography, EMG, comes in. We place small needle electrodes into the muscles innervated by the nerve at risk, for example, facial muscles for the facial nerve, CME7. EMG can detect two things: spontaneous activity, bursts of firing, if the nerve is irritated or stretched by surgical manipulation, giving an immediate warning. Or the surgeon can use a probe to directly stimulate the nerve to help identify and map its course, standard of care for acoustic neuroma surgery.
And monitoring the main motor pathways down the spinal cord. SFEPs only cover the sensory side.
Exactly. To monitor the motor tracts, specifically the corticospinal tract, we use motor-evoked potentials, MEPs. This involves stimulating the motor cortex directly through the scalp, transcranial electrical stimulation, and recording the resulting muscle contraction, usually in the hands or feet, as a compound muscle action potential. A significant decrease in MEP amplitude is a strong indicator of potential motor pathway injury, often correlating well with postoperative motor function.
How does anesthesia impact MEPs?
MEPs are extremely sensitive to anesthetics. Volatile agents significantly suppress or even abolish MEPs, making them very difficult or impossible to monitor reliably. Neuromuscular blocking drugs, muscle relaxants, also obviously abolish the muscle response. Therefore, when MEP monitoring is crucial, which it often is during complex spine surgery, TVA is essentially mandatory, usually a combination of propofol and an opioid like remifentanil or sufentanil, sometimes with ketamine. We also have to keep neuromuscular blockade very light or avoid it altogether during critical monitoring periods.
So choosing the right monitoring depends heavily on the specific structures at risk during the surgery. Table 31.5.
Absolutely. This raises an important question. Each of these modalities, EEG, SFP, VER, EMG, MEP, gives us a different window into the nervous system's function. The art and science for the elite professional is selecting the appropriate combination of modalities based on the specific surgical procedure and the neural structures at risk, and then interpreting those signals correctly within the context of the anesthetic being administered. For example, complex spine surgery might use both SSHEAL and MEPs for comprehensive cord monitoring. Posterior fossa surgery will definitely use BERs and cranial nerve EMG. It's about putting together the full picture to maximize patient safety.
Okay, let's put it all together now. Let's discuss specific anesthetic considerations for common neurosurgical procedures, integrating everything we've covered. We'll start supratentorial surgery procedures above the tentorium, dealing with masses in the cerebral hemispheres like tumors or vascular lesions.
Right. Patients undergoing supratentorial craniotomy might present with seizures, hemiplegia, aphasia, or signs of increased ICP like headache and papilledema. Preoperatively, the key is assessing for and managing that potential increased ICP. CT or MRI will show mass effect, edema, midline shift. We need to know their baseline neurological status, what medications they're on, anticonvulsants, steroids for edema. Pre-medication with sedatives is usually omitted if there's evidence of high ICP, as it could worsen things by causing respiratory depression and hypercapnia.
What about intraoperative management, monitoring, fluids?
Monitoring will include standard ASA monitors, plus an arterial line for continuous blood pressure and blood sampling, absolutely essential. Depending on the case, ICP monitoring or neurophysiologic monitoring like SFPs might be used. Cerebral oxygenation monitoring like jugular bulb oximetry or NIRS might also be employed. Fluid management is critical. The goal is isovolemia, isotonicity, isoncosity. We typically use balanced salt solutions like lactated ringers or normal saline. Crucially, avoid glucose-containing solutions in hyposmolar fluids, as these can worsen cerebral edema by drawing water into the brain across the BBB. Maintaining normal blood glucose is also important, as hyperglycemia worsens outcomes after brain injury.
And the anesthetic technique itself, induction, maintenance, emergence.
Induction needs to be smooth and controlled, avoiding sudden swings in blood pressure that could drastically alter CPP or ICP. Propofol is often used, perhaps with an opioid like fentanyl, given a few minutes before laryngoscopy to blunt the sympathetic response. A non-depolarizing muscle relaxant facilitates intubation. Positioning often involves elevating the head 15-30 degrees to promote venous and CSF drainage. Careful attention to avoid neck flexion or rotation that could obstruct jugular veins is vital. An armored endotracheal tube is recommended to prevent kinking. Maintenance can be achieved with various techniques. An opioid-based technique supplemented with low-dose volatile agent like sevoflurane 1-MA or isoflurane or eroxygen, or a TIVA technique with propofol and reventanol infusions. Mild hyperventilation, targeting Paxo2 30 to 35 mmHg, might be used, especially before the duress is opened, to help relax the brain and facilitate surgical exposure, but aggressive hyperventilation is generally avoided. Diuretics like mannitol might be timed for dural opening. Muscle relaxation is maintained. Blood pressure is tightly controlled, usually within 10–20% of the patient's baseline.
Emergence sounds particularly tricky.
Emergence is arguably the most critical phase for many craniotomies. The goal is a smooth, controlled awakening, specifically avoiding hypertension, coughing, straining, or agitation, bucking on the tube. Any of these can cause a sudden spike in ICP or bleeding at the surgical site, especially if autoregulation is impaired. This requires meticulous planning. Allowing PACA2 to normalize, potentially using short-acting agents like remifentanil that wear off quickly, preemptively treating potential hypertension with IV Latal or Esmol, and potentially using IV lidocaine just before suctioning to suppress the cough reflex. The aim is for the patient to wake up calmly and follow commands quickly, allowing for immediate neurological assessment. Delayed awakening needs prompt investigation.
No, for something completely different. Awake craniotomy. You mentioned this earlier. When is this done, and what are the goals?
Awake craniotomy is performed when the surgical target, often a tumor or an epileptic focus, is located very close to or within eloquent cortex, meaning areas critical for functions like language, motor control, or sensation. The primary goal is to map these eloquent areas precisely using direct cortical stimulation while the patient is awake and interacting, allowing the surgeon to maximize resection while minimizing the risk of causing a permanent neurological deficit. It's the most reliable way to monitor function in these critical zones.
That sounds incredibly challenging for both the patient and the anesthesia team.
It is. Patient selection is paramount. The patient must be motivated, cooperative, able to lie still for a long time, and understand the process. Thorough patient teaching beforehand is arguably the single most important factor for success, explaining every step, the sounds, the sensations, the need for cooperation. Anesthetically, it's often an asleep-awake-asleep technique. The patient is initially asleep under general anesthesia, often with an LMA rather than ETT, for the painful parts like scalp incision and craniotomy. Precise scalp blocks with long-acting local anesthetics are essential. Then, before cortical mapping begins, the sedation is lightened or stopped, the LMA might be removed, and the patient is awakened. This is the critical awake phase, where mapping and resection near eloquent areas occur. The anesthesia provider must manage anxiety, pain, Dura is sensitive, nausea, and potential seizures, usually treated with cold saline irrigation or a small bolus of propofol. Conversation is kept minimal and focused. Once the critical part of the resection is done, the patient is typically resedated or put back under general anesthesia for closure. What's fascinating here is the awake craniotomy is this incredible example of teamwork and patient participation. The patient's real-time feedback guides the surgeon's hand, protecting function in a way no monitor alone could achieve. It demands incredible finesse from the anesthesia team to keep the patient comfortable, cooperative, and safe throughout.
Let's move down to the posterior fossa. Surgery back there seems particularly risky because of all the vital brainstem structures packed into a small space.
Exactly. Pathology in the posterior fossa, the space containing the cerebellum and brainstem, can directly compromise vital functions. Airway control, breathing, cardiovascular stability, consciousness. Brainstem compression can cause cranial nerve palsies and altered respiration. Obstructive hydrocephalus is also more common with posterior fossa tumors, as they can block CSF outflow from the fourth ventricle. This needs to be identified preoperatively and sometimes requires a ventricular drain placed before the main surgery. Premedication is generally contraindicated if hydrocephalus is present.
And a major specific risk here is venous air embolism.
Yes, venous air embolism, VAE, is a significant concern, especially if the surgery is done in the sitting position, although that position is used less frequently now due to this risk. The sitting position creates a negative pressure gradient between the open veins at the surgical site, which is elevated, and the right atrium. Air can literally get sucked into the venous circulation. It can happen in other positions too, but the risk is highest when the surgical site is significantly above the heart.
Where does the air come from, and what does it do?
It can enter through open bone edges, dural sinuses, bridging veins, even intravenous lines or the pin sites from the head holder, box 31.5. The entrained air travels to the right heart. Small amounts might get filtered out by the lungs, but larger amounts can form an airlock in the right ventricle, obstructing pulmonary blood flow, causing pulmonary hypertension, hypoxemia, decreased cardiac output, and potentially cardiovascular collapse. A particularly dangerous complication is paradoxical air embolism, PAE. If the patient has a patent foramen oval, PFO, a small hole between the right and left atria, present in 25–30% of people, the air can cross over into the arterial circulation and travel to the brain or coronary arteries, causing stroke or myocardial infarction.
How do we detect VAE? It sounds like early detection is crucial.
Absolutely crucial. The most sensitive monitor is transesophageal echocardiography, TEE, which can directly visualize air bubbles in the heart chambers and detect PAE. However, it's invasive and requires expertise. The most sensitive non-invasive monitor, and very commonly used, is the precordial Doppler. Placed over the right heart, it detects the characteristic change in sound when air bubbles pass through. It gives an early warning, often before hemodynamic changes occur. Other signs include a sudden drop in end-tidal CO2, EtCO2, as the air obstructs pulmonary blood flow, reducing CO2 delivery to the lungs. A rise in pulmonary artery pressure, if monitored, can also occur. A late sign is the classic mill-wheel murmur heard with the stethoscope, table 31.7.
If VAE is detected, what's the immediate treatment? box 31.6.
Immediate coordinated action is required. 1. Notify the surgeon immediately. They need to flood the surgical field with saline or pack it to stop further air entry. 2. Discontinue nitrous oxide if it's being used, as it expands the air bubbles. Administer 100% atrium. 3. Attempt to aspirate air through a central venous catheter, CVC, if one is placed with the tip near the right atrium. 4. Increase venous pressure at the surgical site. Maneuvers like the Valsalva maneuver by the anesthetist, applying PEEP or brief bilateral jugular vein compression might help. 4. Increase venous pressure at the surgical site. 5. Reposition the patient if possible, lowering the head, Trendelenburg, and placing them in the left lateral decubitus position can help trap air in the right atrium. 4. Increase venous pressure at the surgical site. 6. Provide hemodynamic support with fluids and vasopressors, like ephedrine or epinephrine, if blood pressure drops.
Positioning itself seems like a major consideration for posterior fossa surgery.
It is. While the sitting position offers excellent surgical exposure and drainage, the VAE risk has led to increased use of lateral, prone, or park bench positions. Whichever position is used, meticulous padding and care to avoid pressure injuries or nerve stretch injuries are essential. Excessive neck flexion, particularly in the sitting position, carries risks of airway swelling, quadriplegia from cord compression, or macroglossia.
Anesthetic management otherwise similar to supratentorial.
Generally, similar principles apply regarding smooth induction, avoiding ICP spikes, secure airway, often a reinforced ETT, careful fluid management, and controlled emergence. However, post-extubation vigilance is particularly important after posterior fossa surgery due to the risk of damage to lower cranial nerves. Then there's excitatory, involved in swallowing and airway protection, box 31.7. Any doubt about airway competence means leaving the patient intubated initially. Let's move to pituitary surgery. These tumors, located at the base of the brain in the sella turcica, often cause problems either by mass effect, compressing nearby structures like the optic chiasm, causing visual field defects, or by hormone hypersecretion.
What kind of hormone problems?
Depends on the tumor type. You might see acromegaly from excess growth hormone leading to enlarged features, potentially difficult airway due to large tongue, larynx changes, hypertension, diabetes, or Cushing's disease from excess ACTH, causing hypertension, diabetes, obesity, fragile skin, or excess prolactin causing reproductive issues. Sometimes they are non-secreting. Preoperative evaluation must assess for these endocrine abnormalities and their systemic effects. Patients might also have panhypopituitarism, deficiency of multiple pituitary hormones, requiring replacement therapy, like thyroid hormone.
How is the surgery usually done?
The most common approach now is transsphenoidal surgery, going through the nose and sphenoid sinus to reach the pituitary. It's less invasive than an open craniotomy with lower morbidity. An intracranial approach might be needed for very large tumors with significant extension outside the sella. Endoscopic techniques are also increasingly used.
What are the key anesthetic considerations for the transsphenoidal approach?
Airway management is key. Access is limited during surgery, so the endotracheal tube, often an oral RAE or reinforced tube, must be securely positioned, usually taped to the chin out of the surgical field. The oropharynx is packed. Careful eye protection is needed. Interestingly, hyperventilation is usually avoided. Unlike other craniotomies where reducing ICP helps, here it can cause the pituitary gland to shrink down into the sella, making it harder for the surgeon to access. Normocapnia is preferred. Bleeding can be an issue as the carotid arteries run very close by. Surgeons often inject local anesthetic with epinephrine into the nasal mucosa to reduce bleeding. We need to be mindful of the systemic effects of absorbed epinephrine. A common postoperative issue is diabetes insipidus, DI, caused by disruption of ADH secretion from the posterior pituitary. It leads to excessive urination, usually transient but requires careful monitoring of urine output and serum sodium and treatment with desmopressin, DDAVP, if significant. Smooth emergence, avoiding coughing, straining that could disrupt the surgical closure is important.
Now, let's tackle cerebrovascular surgery dealing with the brain's blood vessels. A major category here is cerebral aneurysms.
Right. These are abnormal, localized bulges or dilations in the walls of intracranial arteries, most commonly saccular or berry aneurysms that occur at vessel branch points, often within the circle of Willis. Their rupture causes subarachnoid hemorrhage, SAH, a devastating type of stroke with high mortality and morbidity. While many aneurysms never rupture, rupture risk increases with size and certain patient factors.
How does SAH typically present, and how is severity graded?
The classic symptom is the abrupt onset of an incredibly severe headache, often described as the worst headache of my life. Patients may also have transient loss of consciousness, nausea, vomiting, neck stiffness, meningismus, photophobia. Severity is often graded using scales like the Hunt and Hess scale or the World Federation of Neurological Surgeons WFNS scale, table 31.8, based on the patient's neurological status. Higher grades correlate with worse outcomes.
What are the major complications after SAH that we need to manage?
Several critical issues. Rebleeding is a major early threat, often fatal, highlighting the need for prompt treatment, clipping, or coiling. Hydrocephalus can occur due to blood-blocking CSF pathways. Systemic effects are common. Hypertension is frequent, increasing the pressure gradient across the aneurysm wall, transmural pressure in AP-ICP, and rebleeding risk. But lowering BP too aggressively can cause ischemia, as autoregulation is often impaired after SAH. A careful balance is needed, often targeting SPP 120-150 mmHg before the aneurysm is secured. ECG changes mimicking ischemia are common, but not always indicative of cardiac damage. Electrolyte disturbances like hyponatremia from SIADH or cerebral salt wasting can occur.
And the big delayed complication is vasospasm.
Yes, cerebral vasospasm is the leading cause of delayed morbidity and mortality after SAH. It's a prolonged, reactive narrowing of cerebral arteries, typically starting 3 to 5 days after the bleed and peaking around 7-10 days. It reduces blood flow distal to the spasm, causing ischemia or infarction. Angiographically, it's common, but only about half of those patients develop clinical symptoms. The primary medical treatment now involves prophylactic administration of the calcium channel blocker numotine to all SAH patients, as it's shown to improve outcomes. If symptomatic vasospasm develops, the mainstay treatment is often HHH therapy, inducing hypervolemia, hypertension, and hemodilution to maximize cerebral blood flow through the narrowed vessels. This requires intensive care monitoring. Refractory vasospasm might require endovascular treatments like balloon angioplasty or intraarterial vasodilator infusion.
When should surgery, a clipping, or endovascular treatment, coiling, be done?
The trend now is towards early intervention, usually within 24-72 hours of SAH, if the patient's condition allows, e.g. good grade Hunt and Hess III. Secure the aneurysm early prevents rebleeding and allows for more aggressive management of vasospasm, like induced hypertension, if it develops later. Operating very early can be technically challenging due to brain swelling, but outcomes seem better than delaying into the peak vasospasm period, days 4-10. Poor grade patients might have surgery delayed until their neurological status improves.
What are the key anesthetic goals during aneurysm surgery?
Maintaining hemodynamic stability and avoiding rupture are paramount. This means preventing hypertension that could increase transmural pressure, but also avoiding hypotension that could compromise perfusion, especially if vasospasm is present or ICP is high. Smooth induction is crucial, deeply anesthetizing the patient before stimulating events like laryngoscopy or head pinning to prevent dangerous BP spikes. Controlled ventilation to maintain normal capnia or mild hypocapnia is standard. Techniques to facilitate surgical clipping might include temporary hypotension, now less common, or, more frequently, temporary clipping of the parent artery feeding the aneurysm. During temporary occlusion, strategies to protect the brain, like inducing EEG burst suppression with increased anesthetic depth, example propofol, barbiturates, or volatile agent, to reduce metabolic demand are often used. Mild hypothermia was studied but didn't show benefit in good-grade patients, IHAS trial. Emergence needs to be as smooth as induction, avoiding hypertension or straining that could disrupt the clip or cause bleeding.
What if the aneurysm ruptures during surgery?
Intraoperative rupture is a potential catastrophe. The first sign might be sudden, uncontrolled bleeding in the field, and often an abrupt rise in blood pressure. Immediate goals are to lower transmural pressure rapidly. For example, bolus of propofol or nitroprusside to induce brief, deep hypotension, maybe MAP 40-50 mmHg, allow the surgeon to gain control, often by temporary parent vessel occlusion, and initiate rapid volume and blood product resuscitation.
Beyond open surgery, there's interventional neuroradiology, INR, coiling aneurysms, for instance.
Right. INR offers minimally invasive endovascular treatments for aneurysms, AVMs, and stroke. For aneurysms, tiny platinum coils are deployed inside the sac via microcatheters navigated through the arteries, causing thrombosis and excluding the aneurysm from circulation. Anesthesia for INR, table 31.9, requires ensuring complete patient immobility for precise imaging and catheter work, managing anticoagulation, usually heparin during the procedure, allowing for rapid awakening for neurological assessment, and being prepared to manage potential complications like abrupt hemorrhage if the aneurysm ruptures during coiling, or thrombosis occlusion of vessels, box 31.8. General anesthesia is often preferred to ensure immobility and control hemodynamics.
What about arteriovenous malformations, AVMs?
AVMs are congenital tangles of abnormal arteries directly connected to veins without an intervening capillary bed. They often present younger than aneurysm patients, typically with bleeding, intracerebral hemorrhage rather than SAH, seizures, or sometimes steel phenomena causing ischemia in adjacent brain tissue. Anesthetic management shares similarities with aneurysm surgery, focusing on controlling blood pressure. A key difference is that AVMs lack autoregulation. Sudden changes in systemic pressure can drastically alter flow through the malformation. They might be treated with surgery, embolization via INR, radiosurgery, or a combination. Finally, let's tackle head trauma and traumatic brain injury, TBI. This is a huge public health issue, often affecting young people and frequently associated with polytrauma.
What's the primary focus in managing TBI?
The absolute key is preventing secondary brain injury. The initial impact causes primary injury, which we can't undo, but subsequent events like hypoxia, hypercapnia, hypotension, expanding hematomas, epidural, subdural, intracerebral, and sustained intracranial hypertension cause further preventable damage. Box 31.9, figure 31.22. Our goal is to treat the primary injuries surgically if needed, but critically to prevent or mitigate these secondary insults.
So management starts immediately, often pre-hospital.
Absolutely. The priorities are the ABCs, but with a neurological focus. Airway. Ensure patency. Provide oxygen. Assist ventilation if needed. Crucially, assume a cervical spine injury in all significant head trauma until proven otherwise. Use manual inline stabilization during airway manipulation. Intubation is indicated for poor ventilation, lack of protective reflexes, or GCS9. Rapid sequence induction, RSI, is typically used. Avoid nasal intubation if basilar skull fracture is suspected. Abnormal respiratory patterns, table 31.11, can indicate the level of brain injury. The Glasgow Coma Scale, GCS, table 31.0, is vital for assessing severity and tracking changes.
What about circulation and blood pressure?
Cardiovascular. Hypotension is common, usually due to bleeding elsewhere in polytrauma patients, and it's devastating for the injured brain. Identify and treat shock aggressively. Resuscitate with blood products if available, otherwise isotonic crystalloids, normal saline, LR. Avoid glucose-containing solutions. Restoring BP too quickly might worsen edema if autoregulation is lost, but preventing hypotension is paramount. Aim for CPP 60 mmHg, table 31.12, which often means targeting a higher MAP if ICP is elevated.
Coagulation issues are common too.
Very common, especially with chronic subdural hematomas, often seen in the elderly or those on anticoagulants. Need to rapidly identify and reverse any coagulopathy before emergent surgery. For example, vitamin K and FFP or PCC for warfarin. Specific reversal agents for DOACs if available. Platelets for antiplatelet agents. Severe TBI itself can trigger DIC due to release of tissue thromboplastin. Early recognition and treatment with blood components are crucial.
And managing ICP acutely.
Initial measures include head elevation, keeping the head midline, maintaining normovolemia, and controlling systemic blood pressure. If herniation is suspected clinically, or ICP is known to be high, mannitol or hypertonic saline should be given emergently. Remember, corticosteroids are contraindicated in acute TBI.
Once stabilized, imaging is key.
Yes. CT scan is the workhorse for rapidly identifying surgical lesions, hematomas needing evacuation, or signs of increased ICP, cisternal effacement, midline shift. MRI is better for assessing diffuse axonal injury or subacute to chronic changes. Patients needing imaging often require sedation or anesthesia to remain still, but airway control must be secured first to avoid hypoxia, hypercapnia.
What about intraoperative management for TBI surgery?
Similar monitoring as for other high ICP cases. Arterial line, CVP, often useful for volume status. Anesthetic induction agent choice depends on hemodynamics. Etomidate or ketamine if hypotensive. Propofol cautiously if hypertensive. RSI with cricoid pressure, unless C-spine fracture, using succinylcholine if no contraindication, or rocuronium. Blunting the intubation response with lidocaine, fentanyl, or esmolol is important but must not cause hypotension. Maintain normocapnia unless brief hyperventilation is needed for acute brain herniation. Use glucose-free fluids. Extubation depends entirely on the severity of the injury and the patient's post-op neurological status. Many remain intubated for ongoing ICP management and neuroprotection. What's fascinating here is TBI management truly exemplifies the race against time to prevent that secondary injury cascade. It demands seamless integration of neuroanatomy, physiology, pharmacology, critical care, and surgical principles. Every decision, airway management, fluid choice, blood pressure target, anesthetic agent, directly impacts brain recovery. It's not just treating a head wound. It's managing a complex, dynamic systemic illness focused on protecting the most vital organ. #outro.
Wow. We have really covered some ground today.
from the absolute basics of neurons and glial cells, navigating the intricate geography of the brain and spinal cord, decoding the electrical and chemical signals, all the way through to the incredibly complex considerations of neuroanesthesia managing ICP, dealing with VAE, tailoring anesthetics for aneurysms, tumors, awake craniotomies, and traumatic brain injury. It truly underscores that the central nervous system is an absolute masterpiece of biological engineering.
It really does. And if there's one key takeaway, especially for achieving that elite professional understanding we aim for, it's the incredible interdependence of it all. A problem at the cellular level, a disruption in blood flow, a mechanical pressure issue, everything impacts everything else. Mastery here isn't just knowing the individual components, it's deeply understanding how they function as an integrated whole, how they respond under stress, and crucially, how our interventions can protect that delicate symphony during the immense physiological challenge of neurosurgery.
So the next time you simply think a thought, feel the warmth of the sun, or even just take a breath without thinking about it, maybe take a moment to appreciate the astonishing, intricate complexity humming away inside you. It makes you wonder, what other biological masterpieces are we interacting with every single moment, perhaps taking them for granted? And what profound insights might we gain if we truly took the time to dive deep into understanding them?